Good evening, everyone. Today I'm going to introduce Dr. Khalaf al-Shamari. He earned his bachelor degree from University of Missouri, Kansas City, his master's certification of periodontology and implant fellowship from University of Michigan. He is the first Kuwaiti dentist to achieve full American board in any specialty 2001. The former Vice Dean for Research and Student Affairs and Associate Professor at Kuwait University Faculty of Dentistry. Past Chairman and of Faculty of Dentistry at Kuwait Institution for Medical Specialization. Past President of the Kuwait Division of IADR. Dr. al-Shamari is an author and co-author of more than 30 publications in index journals, including high-ranking journals such as Journal of Clinical Periodontology, Periodontology 2000, and Journal of Periodontology. Dr. al-Shamari is also a consultant periodontist and the head unit at Al-Jahra Specialized Dental Center. Dr. Khalaf, thank you very much for facilitating the education in Kuwait here for us as dentists, and for being so humble in delivering your informations and for giving us all the opportunities that we have. Thank you.
Thank you, Dr. Asrar. I really appreciate it for this nice introduction. I don't know whether we should wait maybe a little bit because it seems a lot of people don't know that we're starting, or we should go ahead. Or I'll go ahead and repeat it again. I don't mind, you know. First of all, thank you very much for everyone for being here. It's my honor to do this again after about more than 6 years since my last time presenting. Today we'll be talking about a topic that might seem controversial from the title, but you know, no matter how we look at it, it is important and we have to discuss it because I feel it's basically what we're here primarily to do. People usually start with the objectives of the lecture. Today we will say. I'm going to start by saying what the objectives of the lecture are not. I am not here to assign blame. I am not here to criticize, undermine, or belittle any individual in this system. I'm not going to point out your mistake, you're not doing your job. This is not the goal of what we're doing here today. It is a critical appraisal of the existing system to identify points of concern, highlight any shortcomings, things we may be able to improve, and propose some possible solutions. As an overview for people who don't know, who are not from Kuwait, we basically have a universal healthcare system which the government funds the dental services, where we have primary dental care centers, polyclinics, specialized dental centers, and of course I have to show Jahra as the best center, you know, in the world. And then we have emergency clinics as well. Also, there are private dental clinics available, and you know, it's a growing sector that is growing even more and more. The way the system is supposed to work is, if you have an emergency, you can go directly to the polyclinic, walk in, or emergency clinics dedicated after hours for receiving emergencies. If the patient is stable or for routine treatment, you go to the polyclinic for primary and secondary care. When there is additional treatment needed, then the patient is referred to specialized dental centers for tertiary care. For preventive care, when there is no active treatment needs present, it's supposed to be done by the polyclinic. This system is perfect. It's ideal. In theory, I mean, you've covered everything: emergency, routine treatment, specialist treatment, preventive care, and you allocated which department should receive which cases. However, as we've seen, as we hopefully will see in this lecture, there are several things that we need to take into account for it to work properly. This is a vicious cycle. I'm going to go back to it, you know, multiple times. But basically, if we think of the life journey of a Kuwaiti tooth, of any tooth that is being treated in Kuwait, 99% of the time it will go through 90% or more of these steps. And we'll go through it, a little bit, not in too much detail. However, this impression I'm giving you is from my observation, from your observation. I'm working in a special center. I saw, okay, this problem is happening. So maybe the trend is this and this. But however, this is not how we build any policies. This is not how we build any decisions. The best way is to have studies, to have data, to see if actually this is a trend, this is happening, this needs addressing, or is it just individual situations? So we started developing a series of studies examining different aspects of this issue. I don't think the pointer is clear, however. So basically, the reason we did these studies, because we need baseline data. If we want to develop, population-based oral health care plans, we need to identify what the problems are that we should address. Assessment of the oral health awareness and patient education aids in formulating preventive programs. Basically, if you want to teach your patients or engage them more in prevention, you need to assess how much they already know, how much they don't know, and what areas need improvement and assessing. And then assessing the oral health status and treatment needs identifies areas of focus for prevention and therapy. For example, how common is periodontal disease in Kuwait? Do we have enough periodontists based on that proportion of periodontal disease prevalence? What's the rate of caries in Kuwait? Do we need to have more restorative dentists because the caries rate is high or low? So before, how many prosthodontists we need to send to study, to specialize? How many oral surgeons, and so on? For that, you need basic information telling you how common each specific oral problem is present in Kuwait. So one of the first studies we did was a survey. We attempted by this survey to see dental visit patterns and attitudes towards oral health care, and also evaluate patients' own self-reported dental treatment needs. Like, I have this issue, I have this issue, and in addition to their oral hygiene habits. I want to stress the educational background when we analyze the result. Most of the participants had at least high school education, and 83% of them had high school education. So this is a very well-educated sample, which represents the Kuwaiti society. If you go to the Ministry of Planning statistics, most of people in this age group, around 30-something years old, are highly educated. Toothbrushing, without going into details for everything, as seen in most other studies internationally, more frequency by females, but overall, about 38% of subjects brush less than twice a day, which is the ideal that we request them to do. And for flossing, it was even, very clear, only about 12% floss daily. Now, this was before the introduction of water jets and water picks and water floss. My impression is that this would be higher now because it's so much easier to use, and there are studies outside that show that water floss devices have increased the compliance with flossing. Still, at that time, and I think still at this time, it's not the ideal that we look for. When we asked them to, mark any oral health problem that they have, we had all kinds of problems. I highlighted a few things. Bleeding when brushing, which is a very common, thing we hear when the patients come. My gums brush when I bleed. But brushing when eating, this is very significant, very serious. If somebody, bleeds while they eat, their gums bleeds while they eat, and they think it's normal, they don't go seek treatment for it, it shows you there is, great need for education about aspects such as this. Gum pain, a lot of people come to you and say, my gums hurt. We know that in perio, very few things actually cause pain in the gingiva. However, their ability to express discomfort is only related to the word pain. So when they come and ask you that, I have pain in my gums, you have to examine and you will usually find something else, not necessarily pain, but a sign of disease. A lot of them are having transient pain, continuous pain. So people are, there, they have pain that is continuous or comes and goes, and they're not seeking treatment for it. When we look at reasons they don't go and get preventive dental care, everybody will tell you we don't have time, right? So this was the most common response, right? However, this is the most significant one. Dental visits in the minds of the majority of the people in Kuwait are not needed unless you have pain. So why should I go to the dentist unless I have pain? This is a major issue because it will explain a lot of things that we will talk about later. And some of them complain that it's difficult to get an appointment, there are long waiting periods and issues like that. Fear of dentists was also significant. Without going into details about all the specifics, when we did regression analysis to isolate the factors that are not really significant but confounded by other things, it was true that the main reasons, if you don't have pain, I shouldn't go. This is a very valid reason in the patient's minds. And because appointments are too far ahead, this is the reason they don't seek preventive care. And for those that have less than optimal compliance with brushing and flossing, also they're the ones not likely to go for regular care. So factors associated with not having a preventive dental visit for more than 1 year. When we saw when was the last time we had prophylaxis or examination visit, never was almost 40%. They've never had a visit like this. Over 1 year was another 30%. So over 70% of patients have not had a preventive visit for over a year. And the factors associated with that are lower educational level, poor oral hygiene habits, believing that visits are only needed if there is pain. I'm stressing this point because it explains a lot of the shortcomings we have. Believe that appointments are difficult to get. So in summary, for that study, the points that we can use to help us decide how to plan our oral health care policies. Despite the high level of education of the sample, most do not perform adequate oral hygiene measures. Remember, up to 40% don't floss, don't brush their teeth daily. Most do not follow a regular preventive care program. 70% haven't seen the dentist for over a year. Approximately 1/3 of the subjects are missing one or more teeth, which are lead to functional deficits, replacement costs. There is a high prevalence of periodontal complications like gingival bleeding, halitosis, sensitivity, and then a fairly high incidence of complications that affect general well-being of the patient. For example, pain, either continuous or transient, infection. Some of them tell you I have pus, active pus in my mouth. They report it freely. Xerostomia, TMJ, and mastication problems. And just to make sure everybody's awake, we're going to have to throw a picture like this every once in a while. How often do you see this? How commonly do you see this? As a non-periodontist, maybe less. As a periodontist, I can say, probably on a daily basis. But unfortunately for almost everybody here, I'm sure you do see this almost on a weekly basis. The next step, we went and looked at dental emergencies. Here we have, emergency centers in every government, and they receive patients without appointments. They're open after hours. They open 24 hours a day now in a lot of places. So what we did, all cases seeking emergency dental care for a period of 30 days were asked to complete and write chief complaint, diagnosis, treatment provided, and all information regarding the patients. Not surprisingly, pain is the most common reason patients seek emergency care. And then swelling, lost filling, trauma to the teeth, trauma to the soft tissues, gingival bleeding, decay, other issues. From this, and then we did a more thorough analysis I didn't want to place here. actually a lot of things can be learned, like difference between a chief complaint and a diagnosis, a true emergency rather than an inconvenience, a lot of things like this. I just want to keep focusing on the aspects that are important to us. Diagnosis, most of the diagnoses were, pulp-related issues. A few were perio and other issues. Treatment provided, pulpectomy, extraction, temporary fillings were the most commonly done. Look at the scaling. People come for scaling. Do you think it's unusual that somebody comes for a scaling to an emergency dental clinic? One of the stories, one of the people who work there told me is 2 o'clock at night. Somebody comes and, what's the matter? What's wrong? What can we help you? No, I just want scaling. It's like, okay. Why are you coming, now? Why don't you go to the polyclinic? I said, I was, just came out to Duania and there's nothing to do. I thought maybe it's a good, this is an emergency dental clinic, So I'm not blaming the patient, I'm not blaming, but it's just, this is the point I want to go to at the back again. The availability of dental services 24 hours a day is a good thing, but maybe not such a great thing. And I'll explain a little bit later why. So in summary, dental emergencies are very common, or visiting the dentist for emergencies in Kuwait is very common, very commonly done. Most are endodontic problems. There are some periodontal problems as well. There are caries, trauma. What we did is we divided or combined these into preventable and non-preventable. For example, trauma or eruption, exfoliation problems. These are things you cannot control. They will happen no matter what. However, things you can prevent with good oral hygiene, with proper maintenance visits, not having caries that will get bigger and then get into the pulp and cause you pain. 79% of so-called emergencies are preventable, can be prevented. So this ties with the first study, with the level of oral hygiene, with the level of preventive care. You see, we're trying to connect everything together to try to reach to better understanding of the state of our patients. So in summary, a significant proportion of patients seek emergency dental care, many for non-emergency situations that can wait and can be done in other places. Most are preventable with adequate oral hygiene and regular preventive visits. This has an impact on care provision. For example, am I doing my job correctly in the polyclinic? If my patients do not know, they can come to me for non-emergency situations. And workload is put on emergency clinics that shouldn't be there. Just a side note, one of the referrals, for example, ability in the lower teeth and needs a chief complaint, patient complains of mobility. He also gave a suggested treatment, no medical history. If he cannot really see or diagnose or report, this we did, we just looked and then we took an x-ray, and it's a completely different situation with the patient to make sure that you're sending them. This turned out to be a next topic. We want to see reasons for tooth extraction in Kuwait. This is done almost survival of teeth. What causes the loss of teeth? So what we did is we went to 21 polyclinic and we asked them to record information. Without going into details, caries will be the most common cause for extraction. As the patients get older, periodontal of interest is this right here. Patient request, we put it as one of the choices for the dentist. Is it stated with the tooth being recorded as lost for periodontal disease? Never brushing or having terrible oral hygiene history is also not surprisingly significantly associated with losing a tooth for periodontal disease. These things, common sense. Why do we do studies on common sense things? Because not everything, as you know, that makes sense turns out to be true if you research it properly, in a proper way. We need to have that data so that we don't build assumptions unless we have actual facts supporting our decisions. So, in summary, for this study, most extractions are due to periodontal disease in older patients and then carried in younger patients. There is a significant percentage of people who refuse alternative treatment, even though the tooth should not be extracted, they insist on the tooth being extracted. And extractions due to periodontal disease are significantly associated with inadequate brushing habits and lack of preventive visits. This is related to insisting on refusing any other treatment. And also, I mean, what do we do if somebody comes and he or you forces you, or you decide this tooth has to be extracted? Now we're talking about the polyclinic setting. They come in, they have pain, tooth is not restorable, has to be extracted, now you extract it. What should you also do? I mean, go ahead, do the extraction, but what else should you do, especially now, day and age? You should discuss replacement options before you remove the tooth. So in that same study form, we asked the dentist, what did you recommend to the patient? Whether it be an implant, removable, fixed, treatment, or none. And the majority had of patients, they were offered no options or the option not discussed. Just take the tooth out. What's the problem of doing that? You're relieving the patient's pain, you're doing the patient a service. What is the likely problem that will occur if you just do that? And you probably see it frequently if you've done your rotations in specialized centers. You can engage. I mean, I actually like it this way. If people respond, I can hear you. No wrong answers. Okay, no stupid answers. Okay, no answers. That's okay as well. What happens when you first extract the tooth to the bone around it? Lots of studies, this is one of the older ones. When the tooth is extracted, alveolar bone is still in a good shape for about a year or so. Good shape meaning that the volume of the bone, both width and height, is still maintained. Why is that important? Because if you want to place an implant in that position, this is very significant. What studies have shown is that 25% volume loss in the first year, so anything between first 6 months to a year, your situation is almost ideal, okay? If you go more than 1 year, you start losing width. The first pattern of loss is width. Height is still okay. As you go from 3 years and beyond, you start losing height. Now, why is this also significant again? Because even if you lose width, grafting techniques that we use to increase the bone work very well or very predictably when we try to augment width. However, when we try to augment height, they're not very predictable. So we always try to catch the patient not too long after the extraction if they want to have an implant. Otherwise, the procedure will be much more complicated and sometimes even not possible to do. Another thing is, patients lose the tooth, they are not offered treatment options. They go on with a missing tooth, they think this is normal, and then, they read it somewhere on, social media that there is something called an implant. They come to you to replace this area, then they reach you, unfortunately, at a stage where, it's too late and the procedure is becoming, very difficult and time-consuming and, financially consuming. Last study, we looked at the prevalence. We don't have a lot of data on how prevalent periodontal disease is in Kuwait, so we did a study back at the university with the little, information we had. So we looked at the panogram OPGs of patients in the Kuwait Dental School, and we, looked at them, and we looked at by sextant to see the amount and percentage of bone loss. around 56% had no or mild bone loss. However, 25% had one or more sextants with severe, moderate to severe bone loss. So within the limits of this study, we can estimate that for that subgroup of patients, a moderate to advanced periodontal disease is present in about 1/4 of the patients. Last one we did, and it's not, my job, I'm not an endodontist, but I was appointed as the director of a center in 2005. Dr. Asmahan was there. That center has endodontics and periodontics only. So, as the head of the center, every day I have patients who need endo coming and fighting and, almost causing, bigger issues because they cannot get an appointment, So I talked to my endodontist sitting there. I said, what's the problem? What's happening? They say, well, the appointments, because the patients are not ready when they come, we have to give them an appointment to change the access cavity and then another appointment to start treatment. I said, okay, do you have any information, any data? You're telling me most access cavity preparations done in the polyclinics are not adequate, but do you have any data? They said no. So we prepared a little form, and I asked them to write for every access cavity they receive, adequate, not adequate, and the reason. Just to relieve the headache I was getting from the patients, so I can speak to the, Idara and tell them, you know what, you need to tell the polyclinics to do this and this and this. And this is what we found. It was a small access. 48% of the cases had an inadequate access cavity preparation. I'm not talking about this one. This could be excellent. I don't know. It's not my specialty. Just an example of what an access cavity is. Small access that was insufficient for proper instrumentation was the most common. Residual caries, undermined enamel, and even perforations, okay? So now I have this data. I can use it with the other data I collected from the other studies to start to build a model where I can imagine what the proper treatment should be. So summary of all the studies we talked about. Study Kuwaiti adults report less than optimal oral hygiene habits. They're not great in oral hygiene level. Do not seek regular preventive dental care. Seek emergency dental care for mainly preventable conditions. They're overloading the system unnecessarily. And then they report several barriers to seeking preventive care. The main one is lack of awareness of the importance of preventive care. Remember when they said, there is no need to go if I don't have pain. Why should I go? So they don't know about preventive care, believing the system is inadequate because they say, okay, even if we want to go, it's going to be long waiting periods and appointments will take too long. In addition, tooth extraction strongly associated with poor oral hygiene and lack of preventive visits. So you see how things are tying together? Replacement options are not commonly discussed, and then 25% of our patients exhibit signs of moderate to severe periodontitis. Now we go to our vicious cycle model, okay? Took me some time to do this, so you have to bear with me, and we'll go one by one. And hopefully it will start making sense. I'm not making fun of the system. I'm just pointing what we see. So pain, why do we start with pain? Because this is the most frequently thing we've seen. Patients report they have pain. They go to emergency clinic for pain. If you have pain, you have two options. The cause could be caries or sequela of caries, or it could be perio, very rarely. But if it's caries, usually it's some symptoms of pulp issues. A pulpectomy is needed. This is done either in the emergency clinic or in the polyclinic, right? So this is step one, and this is for the majority of patients that have pain. You examine the patients, you do your test. Patient has an endodontic issue, they need a pulpectomy, you do your pulpectomy. What's the next step? Referral to endo, right? Well, you're supposed to finish all the primary care needs first, right? Otherwise, they will send the patient back to you. So this is one point. The patient's in pain. They want to refer right now, but you cannot refer them unless you finish all the caries and other things. So there is a little, tension in that issue. When they go to endo, what do? Root canal treatment, right? if they do root canal treatment, what's the next step? Send them back to you to do a restoration, right? Even if the tooth needs a crown, they will send them back to you to do a build-up, and then they go back to pros. However, if the tooth, is broken down, they need access for the clamp, they send this to perio. So now perio is involved. So started with endo, now with perio. To do a crown lengthening, just to allow them to place the clamp to finish the endo. So we do this, they do their endo, they send it to a polyclinic. Polyclinic then sends it back to pros to receive a crown, if the tooth needs a crown, which in a lot of cases it does. Now, sometimes when it's not sent to perio because they can place their clamp, and it goes to the polyclinic, comes to pros. Pros is the department responsible for seeing restorability from non-restorability of this tooth. So at that point they discover they need a crown lengthening after the endo was completed, so they send it back to perio. You know what I mean? What's the proper solution? This probably should have been sent, if there is a question, to pros first to determine the prognosis before they do a root canal, before they do a crown lengthening, and then may decide the tooth is not restorable, so it should be extracted. You know what I mean? You understand the cycle that they went through that they shouldn't go through? Patient comes in, questionable tooth in terms of how badly broken down it is. It does need endo, but will endo be enough to later restore the tooth? At this stage, this patient should go to pros before they go for crown lengthening or for a permanent restoration, to try to avoid this part of the cycle over here. Let's say everything is okay, the tooth doesn't need extraction, but it went through crown lengthening, it went through a build-up. Another issue before I continue, what's the problem of having a build-up or restoration in the polyclinic and then going back to pros to receive a crown? For you as a prosthodontist, as a restorative dentist, would you prefer working on a build-up that you did or a build-up that was done by somebody else? In terms of not they're doing better or worse than you, but in terms of you knowing the specific situations involved with this particular tooth. So ideally, in my opinion, in the opinion of almost every prosthodontist I spoke to, the build-up should be done in pros. They don't do it this way because of the issue of time, the load of patients. They have to send the patients back. So hopefully everything is fine. We didn't have to go through this and all this trouble and then finally extracting the tooth after going through perio, crown lengthening, and endo treatment and everything. The tooth is fine. It's been restored. So this is the other pathway it may go to. Unfortunately, very likely it will be extracted in a few years. Why? Because it's already compromised. It had crown lengthening, so the bone around it already is, even more compromised. It has a build-up, post and core, maybe retreatment of root canal. The tooth has all the potential, and a big percentage of them do. After a while, they need extraction. However, they do it in a sudden ways. They're fracture. So either send back to the polyclinic, but most cases have to go to oral surgery again for extraction because they require surgical extraction. See how our cycle is building? Everybody's getting involved. Tooth is extracted. What do we do now? We need to replace space again, right? So we send it to pros to plan implants. So they go to perio or oral surgery to plan the implants. We talked about everything here except ortho, right? Now, ortho comes into question here. Why? Spaces. Because if you want to have an implant, you have facial-lingual, mesiodistal, and occlusal, measurements you have to check. And maybe this is the first time patient realizes they need ortho, or they're planning to have ortho, but they think they can do it after they do implants, which is not possible, right? We always tell the patients, if you want to do implants and you plan to do ortho, you have to do the ortho first. because once you do implants, you cannot do ortho anymore. So this is the point where ortho gets involved. Let's say ortho is not needed, implant is ready to go. Where do they go now? We place the implant, they go back to pros. I should have waited a little bit on this. They do an implant, it's beautiful, everybody's happy. Implants are the cure for all dental problems. However, there is, another issue is periimplantitis, which is more and more common than, we like to admit. And it's been ignored previously, but now there's a lot of attention and research on the frequency of which it occurs and how do we manage it. So what happens when you get periimplantitis? It goes back to perio. So this is the cycle I'm talking about. All departments are involved, which is not wrong because this is our job. However, this cycle that the patient goes through, now we tie it to the studies that we showed you before. Not just lack of coordination, but a lot of it can be avoided by following the simple things we talked about before. Show you a couple of cases quickly. Patient, I don't have the whole, histories and backgrounds for all of them, but access cavity, actually not too bad. Root canal treatment is actually not too bad. However, because the tooth is already, badly broken down, appointment issues, it fractured before it went to pros and had to be extracted. Before sending it to, to evaluate for implants. So it was a surgical extraction, they removed a lot of bone, not considering that they will do an implant in the future. We ended up placing an implant, but it wasn't, an ideal situation with the bone graft and everything. So this is very quickly, not too much. This is an old case, so sorry for the quality. It's from, normal x-rays before turning digitals, and we just took pictures of them. And the patient already had the situation here, now it's here, and a little bit here. My point here is, you're already seeing this is, happening to the patient. Wasn't there a chance for, intervention in terms of the importance of prevention here before this happened, or before this happens, or before this happens? What you're seeing here, in my opinion, is a sequence of treatment, no education. Patient goes home, has another problem, okay, we fix it. They have another problem, we fix it. I don't see the role of, education and prevention here. So the same thing, access cavity, endo treatment, permanent restoration, crowns, and it survived. I don't know what's going on here from the beginning. It's there, and quality of root canal, but however, it was there for quite some time, 10 years or so, okay? Then one of them fractures, they remove the crowns to see what's underneath. To my surprise, I feel like this and this are worse off than this one. It looks like they're worse in terms of ability to restore than this one, but the middle one was extracted and the other two were crowned, and it was sent for an implant. I want to ask you, this brings up a point that patients always ask about. Are implants always better than an FPD? When you have a choice, you have a missing tooth, you have two adjacent teeth, you can do an FPD or you can place an implant. Are implants better or is an FPD better? What do you think? Implants, because if they fail alone, true. However, is this always the right answer? Can you think of other situations where an FPD may actually be better or as equal to an implant? Why? This is another reason. If they fail alone. What's another reason we don't, prefer doing FPDs when we can do an implant? Is if you have virgin teeth, no restorations, there is no need to, prepare two adjacent teeth just to add one more tooth, right? So if the adjacent teeth have no restorations, no crowns, we will almost always go with an implant. However, both these teeth already had crowns, need to be crowned again, need to have replacement. So an FPD could be an option. In cases like this, you would lean 50-50 towards an implant or an FPD. However, why did we decide to go with an implant in this case, even though we could have done an FPD without compromising or damaging the adjacent teeth? If you look at the status of the adjacent teeth, already crowned, crowns need to be replaced. Long-term prognosis may not be that great, you know what I mean? So this is a case where, you know, if you, like you said, you place the implant, so if these teeth failed, at least you have the implant, and you don't have to worry about the implant site failing as well. Just a couple more cases and we're done. This is without going into too much detail, just shows you here and here. Almost all the teeth have gone through this cycle of access cavity, root canal, crown, and then failing, extraction, until, you know, we reach the implant stage. Peri-implantitis, like I said, I mean, this is, once it happens, it's even worse than severe bone loss and periodontal disease because it progresses very quickly and options for treatment are very limited. So, looking at all this, you know, together, what are the implications from what we just saw now? You know, is the system of care delivery a deterrent for seeking preventive care? Do people believe that it will take forever to get an appointment to have preventive care? Some of them, like we saw, feel that. Are patients uninterested in preventive oral care? Is it an issue of knowledge? They don't know it's important, or responsibility? And I'll touch on that point a little bit more. Is the workload of primary care providers overwhelming? Of course, all of you will say yes, and I believe it is. I mean, when do I give time for preventive care when I only get 20 minutes per patient and patients are outside screaming and they want treatment for pain? Where do I have the time to focus on prevention? Will the patient even accept that I do that? And then we have education programs for, you know, school oral health programs for kids, but do we have anything for adults? Maybe we should also have something for adults. So, in conclusion, comprehensive oral health care education should be present to raise awareness in Kuwait. I mean, I think that's very clear. Preventive oral health programs should be extended to include all segments of society, not just children in school oral health programs. Systems of delivery need reassessment and reestablishment of priorities. Should we stay treatment-oriented, or should we try to shift into more prevention-oriented? I like this, so I stole it from somewhere. I'm sorry for the copyright's not there, but what it says is selling prevention is hard. Selling cure is easy, you know, and it's true. Most of us or all of us will go with something that will, you know, treat the problem quickly without much effort on our part. This is a personal reflection. 2 minutes maybe? Okay. This is not, we talked about evidence-based, 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 which is the way it should be. I gave you what evidence-based information and conclusions we have. This is my personal reflection. Little bit evidence-based, but a lot of it is personal feelings. I feel the main problem is we have an absence, I'm not going to say lack or, you know, no, complete absence of a systematic, organized approach to preventive care. Okay? There is no system that tells you, protocol, this is how you take care of your preventive patient needs. When this is not there, there is a huge variation from every area to every clinic to every polyclinic to even every clinic within the same polyclinic in terms of the standards of care. If you go to a dentist who believes in the importance of care, attended lectures like this and felt and learned that they're important, they will practice that. Other clinics, they will not. This should not happen in a system. This should not, you know, should happen an individual clinic, but on a system, there should be an audit system, monitoring system, to ensure no matter where you go, you get the same standard of attention. System pushes towards focus on teeth, not patient level. We're treating teeth, we're not treating patients for the majority of cases. I'm a periodontist, I have a case for crown lengthening, okay, I do my crown lengthening. I'm a prosthodontist, I'm supposed to restore this tooth. Even if I see a periodontal problem, I will send it to the periodontist. There is no overall monitoring of the patient at the patient level, not at the tooth level. Now, this is a sensitive area. Patient responsibility in the oral care duty is not adequately emphasized. Why do we put the blame on ourselves for everything? Why do we allow the patients to put the blame on us for everything? They need to understand that we tell them, oh, 50% on the patient, it's sometimes more than 90% on the patient. If they don't do what they have to do, nothing will work. Why don't we do this? Can it be done in a society like Kuwait? Very difficult, because it's being recorded, okay. Because we're used to, whenever we need something, we want something, any time of the day we go and a clinic should be open, right? You see in social media, people complaining, I went to this center at 12 o'clock at night to get a scaling, and there was nobody there, you know. So this is a mentality of the society, of the country, which is, you know, alhamdulillah, we live in such a country where services are always available, but maybe we should start thinking of changing that mentality. Private sector, and again, this is being recorded, private sector engagement in promoting importance of preventive care should be more. They have access to more media and social, you know, media influence than, you know, government sector. Maybe we should shift a little bit from purely aesthetic surfaces, Invisalign, veneers, and try to give a little focus to prevention care. Maybe patients will receive, because they get most of their information now from the private sector. Last thing I will say is that despite all these problems and difficulties, there are many valiant individual efforts, valiant as in, you know, heroic, and true desire to make a difference by a lot of you. And I know that, I see it. Even though there is no support, even though you feel you're not changing anything, you by yourself, you're not making a difference, don't stop. It's these small little things that will eventually, hopefully, make it the rule instead of being the exception. And for these two, they used to come to my room and wonder, what is my dad doing all the time, not playing with us? And I hope you're sitting here, you're not skipping, so now you know. This is what we've been doing all this time. Thank you.
Thank you, Dr. Khalaf, for the informative lecture. Any questions? Thank you so much.
Thank you.
Yeah.